Good morning, everyone. Thank you for joining us for part 2 of our webinar on the challenges and opportunities associated with advanced care planning. We started session 1 last week on October 26th. It was quite an engaging conversation that started with volunteers from the National Patient Advocate Foundation who told us about how advanced care planning had impacted people with serious illness and their loved ones. They shared their compelling stories. We shared a definition of advanced care planning as a process that supports future goals and wishes. And then we heard from experts in the field who interpreted the evidence base for advanced care planning. It was a fantastic session. We thank the co-chairs of the planning committee for that and encourage you to listen to it if you haven't had an opportunity to do so already. Today, we'll dig into part 2 of our webinar and let's get started. The next slide, please. Here's where you can find information about the work of the roundtable. That is putting on this webinar. The roundtable fosters an ongoing dialogue about improving the care of people with serious illness. And our work is really divided into 5 priority areas, communication and advanced care planning being one of them. I want to thank our sponsors. This work would not be possible without the tremendous participation of the sponsoring organizations that you see on your screen here. If you go to the next slide, please. All of the materials from last week's session and today's session will be recorded and archived, and you can access them via this link. The Workshop Planning Committee, as I've noted, has done a tremendous job in putting together just such a compelling program. And I specifically want to thank our planning committee co-chairs. This has been a labor of love for them, I know, but it's also, and it shows in the work that is being done and what you'll hear today. I want to thank all of the members of the planning committee for their commitment to this work and their terrific efforts on our behalf. And I want to thank the roundtable staff who are the utmost professionals who make this work look seamless. They pull together all of the volunteers and experts to allow us to delve into these topics. So I specifically want to thank Lori and Caitlin and Anisha for their terrific support of the roundtable and for making all of this possible. Thank you. Next slide, please. And then I think I'll turn it to James Tulsky, my co-chair, to share a summary of part 1 of our webinar.
Thank you so much, Peggy. I really appreciate that. I just want to briefly say that it was almost 18 months ago when we first thought of this idea of doing this workshop on advanced care planning. As I mentioned last week, there was a lot of discussion at the time as to whether or not there was anything new to say on the topic. A number of people around the room felt that there was a lot of evidence that had come forward in the last number of years that had not been sort of discussed in a forum like this, and there were perhaps new ways that we needed to think about this topic. I think that our experience with COVID has even brought advanced care planning more into the fore. So this has been really timely, and we're all thrilled by last week, the rich discussion that I think really said why it was that such a conference was so important at this time. So what I'd like to do now is just to introduce Dr. Susan Hickman, who is a professor at the Indiana University Schools of Nursing and Medicine and is a director of the Indiana University Center for Aging Research. And Susan is going to provide a bit of a summary for us on the first part of the webinar that we held last week. Thank you so much, Susan.
Thank you so much, James. I was given the very tall order of summarizing last week's rich discussion, and I appreciate the opportunity. We did hear from a variety of perspectives during the webinar, as was suggested at the opening comments by Peggy, including the voices of family members Mo Stewart and Y. Woods Harris from the National Patient Advocate Foundation. These women very generously shared their moving personal stories of their experiences caring for loved ones through the course of serious illness and end of life. And although each discussed ways in which the healthcare system had failed them, they concluded that proactive conversations about goals, values, and preferences, while hard, are incredibly important. Bernie Lowe and Rebecca Sidori provided a grounding framework for understanding the historical context of advanced care planning and its evolution out of landmark case law, as well as significant advancements in developing consensus about how to define ACP and measure outcomes. Specifically, a 2017 Delphi panel agreed to the following consensus definition. ACP is a process that supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. This definition helps us move away from focusing only on documents and treatment decisions to preparing for communication and in-the-moment decision-making. In session 2, I moderated a panel that included Sean Morrison, Carol Montgomery, Darren Highland, and Pat Bomba, and each presented their interpretations of the evidence for advanced care planning, followed by a spirited but short discussion. I'll summarize the key takeaways. First, the evidence base for ACP is equivocal due to significant quality issues in past research, as evidenced by a 2018 systematic review of systematic reviews by Jimenez and colleagues, but it was argued as a result that we know enough to move on. Although there have been prior high quality studies, these were often based on old conceptualizations of advanced care planning. And as the field has matured, there is actually growing recognition that ACP is very complex, and several of the panelists spoke to this. The complexity includes that conversations may change based on patients' readiness and where they are in their life trajectory. There are many stakeholders involved in the process of ACP: patients, surrogate decision makers, the community, clinicians, health systems, and policymakers. And yet, no one discipline or profession owns it. So part of that complexity is understanding what outcomes are reasonable to expect, as the holy grail of goal concordant care may be hard to measure, and other outcomes, such as improved quality of life, may not be appropriate, particularly in a population nearing the end of life. We are also increasingly developing consensus about measurement and meaningful, realistic outcomes. A recent review of 69 randomized control trials conducted in the past 10 years suggests positive outcomes in important areas, most notable for decreased surrogate distress, an outcome that patients tell us is of utmost importance. Some argued that we are in dire need of more research in several areas, including supporting patients in developing authentic value statements, the use of decision aids to support decision-making in the course of serious illness, implementation science that takes into account the local context and tailors interventions to resources that are available in the setting, informatics and platforms such as eMOLS, which hold the potential to improve quality through standardization of conversation elements, increased accessibility, and real-time updating, and pragmatic trials that aim to conduct science in the real world to overcome barriers that frequently prevent successful clinical trial outcomes from being widely implemented. There were interestingly differing opinions about what constitutes advanced care planning. One perspective argued that discussing goals of care in the context of making treatment decisions, which many consider to be part of informed consent, is distinct from ACP. More broadly held view was that these activities often fall along the continuum of ACP interventions, ranging from identifying a surrogate to preparing patients for serious illness decision-making. There was also disagreement about when patients with serious illness should be asked to engage in the ACP process. Some panelists argued that preparation for in-the-moment decision-making should be started in advance of a medical crisis, and other panelists were in favor of a just-in-time communications model with clinicians instead. Importantly, some panelists noted that there are concerns about how these models meet the needs of underserved and disadvantaged patients who lack access to healthcare, minority communities who've experienced systemic racism and therefore mistrust the system and clinicians, or people with dementia or cognitive impairments who are unable to express their preferences and are poorly served by just-in-time decisions. The speakers agreed that evidence suggests advanced directives alone are inadequate and that early advanced care planning should focus on identifying, preparing surrogates, and identifying broad goals, but generally should avoid treatment decisions as it is difficult to anticipate the context in which these decisions will apply. Additionally, the first days panel agreed with preparation as a key component of ACP and that clinicians need to know patients' values and goals to help support the best high-quality decision-making. Despite the evolution of the field from an end-of-life treatments and advanced directives to a process of preparation for medical decision-making, and despite the consensus definition that I started with that was created by the Delphi panel, there really were different opinions about what even constitutes advanced care planning behaviors. It was discussed that the consensus Delphi panel definition may need to be revisited and should include input from patients and caregivers to guide future research and practice. In conclusion, to move the field forward, the panelists agreed that we need to identify the outcomes that the process of ACP can reasonably be expected to produce and evaluate interventions in real-world settings that take into account the complexity of advanced care planning. Thank you.
Thank you, Susan. As I said earlier, the materials for these two virtual workshops can be found at the National Academies website, and you see the links to the recordings on the screen in front of you. This part 2 is thinking differently about advanced care planning, and I will turn it over to the planning committee to run through the remainder of the slides.
Thanks, Peggy. This is Joanne Reif-Snyder. Welcome to everyone who's tuned in today for this second part of our two-part webinar on advanced care planning. And welcome as well to our participants for today. We're really happy to have you here, and we're happy to have you back again if you were able to attend last week as well. Susan Hickman, that was a terrific summary of last week's workshop. Thank you so much for that. And at this time, I'd like to introduce Dr. Kimberly Johnson, who will moderate our next session on thinking differently about advanced care planning. Dr. Johnson is both a member of our workshop planning committee, and she is Associate Professor of Medicine at the Duke University School of Medicine. Kimberly, welcome, and I'll turn it over to you.
Great, thank you so much. Good afternoon, everybody, and thanks to the National Academies and to the Workshop Planning Committee for inviting me to be a part of this really important workshop. As Susan so beautifully summarized, really on the heels of last week's session, which included a rigorous and thorough discussion of the evidence for advanced care planning. I'm really excited about kicking it off with this session, thinking differently about advanced care planning. I think it's an opportunity for us to really consider approaches that maximize the benefits of advanced care planning for seriously ill patients and their families while addressing some of the limitations identified in previous discussions. And so let's get started. We have three panelists. They are Scott Halpern, who is Professor of Medicine, Epidemiology, Medical Ethics, and Health Policy, Director of Palliative and Advanced Illness Research Center at the University of Pennsylvania School of Medicine. Rebecca Dresser, who is Professor of Ethics in Medicine at the Washington University Law School, and Anna Goslin, who's Executive Director of the Massachusetts Coalition for Serious Illness Care. Their full bios are present on the website in the briefing materials. And as they speak, please enter into the Q&A. Any questions that you have, we'll actually be able to pose those to the speakers at the end of the session. And so with that, I'll turn it over to Scott.
Thanks, Kim, and thanks to the members of the planning committee for inviting me to participate. The session's been super so far, and I'm really looking forward to hearing what my co-speakers have to say during today's session. So next slide, please. I'd like to start by saying that I completely agree with Sean Morrison's conclusion last week that there's presently no consistent or solid evidence to support advanced care planning. I'll get into that just briefly. But what I really would like to focus on is that it's important, at least to me, to understand whether this failure of evidence to support ACP means that the concept itself is fundamentally flawed, as opposed to the possibilities that its implementation to date has been flawed, or the methods of evaluation of how well it works have been flawed. And that's where I'll really focus today. Next slide. So about 5 years ago, I wrote a commentary where I made the claim that there really was no strong evidence to support nearly anything in supportive or end-of-life care, a claim that didn't sit well with many. But I'm pleased to say I don't actually hold that view any longer. The last 5 years have produced a lot of high-quality evidence in many domains of supportive and serious illness care. I think the comments yesterday, or not yesterday, but last week rather, about the strength of the evidence, particularly in light of Rebecca Sidori's scoping review, really rings true about how much evidence has been generated in this space. But I'd like to note that not all of the studies in that review were truly high quality. They were high quality simply by virtue of the JDOT criteria, which look at things like randomization and blinding and dropouts, but they don't really say anything about the quality of the outcome measures or the methods used to evaluate those outcomes. And so I would question the overall evidence base being quite as strong as maybe it had been portrayed. But certainly it, I think, is a consistent evidence base in the sense that to the extent that we're looking at things like healthcare utilization or goal concordant care or other or quality of life for both patients and family members, there's no consistent evidence that ACP has achieved those desired outcomes. Next slide. So I'll spend the rest of the time focusing on why errors in implementation and/or evaluation may be accounting for this unfavorable evidence base. And these are the 4 things I'll turn to. Next slide, please. So in terms of focusing on treatments rather than goals and health states, I'll try and be brief here because I think both Rebecca Sidori and Bernie Lowe really touched on many of the important problems here in focusing on treatments just a week ago. Next slide. But in terms of trying to provide a little bit of additional context, I'd like to make mention of this trial where we randomly assigned 200 seriously ill hospitalized patients to make choices about life support treatments, either deliberatively or intuitively, just based on gut instinct. And what was notable is that neither approach or both approaches, in fact, yielded identical distributions of choices to receive a variety of forms of life support under a variety of clinical circumstances. And that if anything, the group that was assigned to deliberate may actually have made patently worse decisions. In many scenarios, they more commonly made choices to receive or not receive interventions that would put them into health states that they themselves had deemed equal to or worse than death. So this is a real cautionary note for those who think that decision aids are going to be our way forward in improving advanced care planning. Next slide. In that same study, we actually did a corollary where we asked these people to identify whether a series of health states that are listed along the left-hand column here were equal to or worse than death. And this was just a depiction in the journal The Economist because their graphic editors are a little better than those of JAMA Internal Medicine. But you can see the upshot here that majorities of people actually show that a variety, or actually say that a variety of health states that they could foresee themselves ending up in would be similar to or worse than death. Now, I don't buy the absolute percentages here at all. I think they're completely subject to affective forecasting errors. But what is important is that the work has motivated us to explore whether states worse than death as a concept can be used in greater depth as a potential means of eliciting patient values. Next slide. And so far, I'd say it's pretty good on that front. So this is a study in which a superstar postdoctoral fellow physician scientist named Katie Auriemma has been conducting semi-structured interviews with seriously ill patients. And she's found that nearly all of them are able to spontaneously identify health states that are worse than death. And I'll note that that's a much different task than what we had studied in the prior slide, where we merely asked respondents to rate whether a state that we described to them was similar to or worse than death. The fact that these people can spontaneously identify discrete health states that they would say are equal to or worse than death, and importantly, that they can consistently articulate many reasons for why those health states are worse than death, really gives me a great deal of optimism that this might be one path forward in terms of better elucidating underlying goals and values. Next slide. So the next problem, I think, is we can sort of refer to it as the Goldilocks problem. Too many studies have enrolled patients who are either too sick to benefit from advanced care planning, i.e. it's not happening in advance at all, or too well to benefit, meaning that they have not yet learned what living with a serious illness is like, and so their judgments about what they would want in such a state are not adequately informed. Next slide. So in this systematic review that actually was led by the same physician scientist, Katie Auriemma, actually while she was still a medical student, found that there's a direct relationship between people's level of serious illness and the stability of their end-of-life treatment preferences over time. And this makes sense, right? So if you look at just older outpatients without any serious illnesses, only about 60% of them had stable preferences over time, where 50% would be determined just by a coin flip, because these were mostly binary choices or binary ratings of stability. But then as you get to more progressively ill cohorts, stability improves appreciably. Next slide. Another study that's noteworthy in this space, but on the other end of the spectrum, is this offsite at RCT by Karen Dietering and colleagues. And I think the problem with this trial, much like the original support trial, is that patients were enrolled so late in their illness that it's arguably not advanced care planning at all. And in fact, in both of those seminal trials, the overwhelming majority of patients who were screened for eligibility were excluded because they had either already died or had already lost decisional capacity, really calling into question the utility of the intervention in those settings. There's also very limited survival time left for the benefits of the interventions, if any, to have manifested. So this is sort of the other end of the problem of targeting patients. Next slide, please. Next, I think we've been measuring success with the wrong outcomes. Next slide. So a lot's been talked about goal concordant care, as was reflected in this systematic review. Next slide. And we've been thinking a lot about this, and actually some really interesting work led by my colleague Stephanie Taylor at Atrium Health has shown that this is actually a truly feasible thing, to have blinded raters evaluate the goals of care for patients, and then different raters evaluate the care actually received. And as you can see here, although a lot of goals are not documented, when they are, the rates of goal concordance are actually quite high. And so this is potentially a method for evaluating ACP going forward. Next slide. I see that I'm running short on time, so I'm actually going to skip just to the next slide and just make the point that ACP is not going to work in a vacuum. Even when it's perfectly designed and implemented, that it's also needs to happen in concert with a reimbursement system that incentivizes value-based care, such that there's residential monitoring and a backup plan for people rather than simply rushing them to the hospital. And the final slide is that I think we need new ways to help patients articulate their goals, that these ways are emerging as our methods to measure the concordance of care with these goals. The potential benefits, again, need to be, will only be realized, I should say, in concert with an overall reimbursement system that makes sense. And I would just say that although I don't think there's much good evidence at the moment, I also don't think it's time to throw the baby out with the bathwater, at least not yet. Thank you.
Great, thanks, Scott. We can go to Rebecca now.
Okay, hi everybody. Can you see me?
Yes, we can.
Yes.
Okay, I can't see me, but you're the important ones. So thanks for having me. This, I think, has been such an excellent discussion, and I hope I can contribute a little bit. Next slide, please. So I'm approaching this as conceptually from a policy and ethical perspective. I'm going to focus on particular populations that I think raise issues even greater than the ones raised in general with advanced care planning. And these are conditions in which the decline can occur over long periods. Dementia has come up, but I'm really going to focus on it. It's an increasingly common concern, and we have growing numbers, and I know the baby boom generation, people I know are very worried about dementia. It could all, dementia can come from things like Parkinson's, stroke, and then some of the points I'm making could also apply to people with traumatic brain injury. Next slide, please. So there's been a very sophisticated discussion of advanced care planning in this program, but I think out in the world, in the media, in the public discussion, and even among a lot of legal, clinical, social work professionals, the focus is on you've got to make your directive and then you're set. So combine this view with the increasing concern about dementia, and that has produced recently in the past few years a number of proposals for dementia specific directives. Some of these come from academics. There was one in JAMA a few years ago, and a lot of them come from nonprofit organizations focused on death and dying. So these vary. They allow people to refuse or consent to the whole gamut of medical interventions. Also to refuse feeding by mouth, and in the Netherlands, and there's some discussion of people wanting to be able to do it here in the US, to receive life-ending drugs at a certain point in dementia, such as if they have to go to a nursing home. Louisiana last year passed a law, it was Nevada, passed a law formally recognizing a dementia-specific directive. It's not well written. I find it very confusing, but it the form allows people to refuse even assisted feeding by mouth. Next slide, please. So I think we have to confront the conflicting interests here. People are out there making these things thinking that they will be applied. So should we allow people to discriminate against what I'm going to say, the term later self, so yourself in the future? It raises this clash of values between respect for individual autonomy, for people who are making the directives, engaging in the planning, expressing their preferences, versus protection of people who have a disability. Dementia is a disability. Next slide, please. So these are the three considerations I'm going to focus on. They come up in general, but I'm going to tie them to dementia specifically. And two of them deal with the quality of the choice. And then the third one deals with this issue of what is the moral decision here? Should we allow people to potentially harm themselves at the point where they have dementia and their interests might be different? Next slide. So informed choice problems, we've heard about them in general. Of course, there's so many interventions. How could you possibly know enough information about risks and benefits to make specific choices? An even bigger challenge with dementia is to understand one's potential quality of life. Dementia patients experience confusion, distress, anxiety, and so forth, many problems. But many people with dementia also report and exhibit contentment, happiness, joy, much of the time, especially if they're living in appropriate care settings. And a lot of this has to do with how other people treat them and the environment that they're in. Also, as the condition progresses, people talk about loss of insight. People tend to become less concerned about their losses and adjust to their changed situations. On the other hand, in the general world, there are totally negative stereotypes about dementia. People talk about the tragedy of dementia, and people bring this thinking into their advanced care planning about dementia. Next slide, please. The next concern is, Scott mentioned affective forecasting. So even people who are, say, well-informed about the varieties of experiences people with dementia can have may make inaccurate predictions about how they are going to feel if they get dementia. There's a general tendency we have to overestimate the negative impact of illness on subjective well-being. This is backed up by empirical research. Studies show that people living with a wide range of disabilities are happier and enjoying a higher quality of life than non-disabled people think they are. And as one expert reports, people with dementia often come to terms with the consequences of their disease and adapt to their new circumstances. Family members write about this too, how they wouldn't have expected their loved one to be so happy, but they are. Now, of course, this doesn't always occur, but it does sometimes. Bioethicists have started writing about this concept of transformative experience to explain the decisionally competent person's inability to make good choices about future care. Transformative experiences like becoming a parent, for those of you who are, or developing dementia, can change a person's perceptions and preferences in ways the person cannot imagine ahead of time. Next slide, please. So
don't think we can hear Rebecca right now. Rebecca, are you able to hear us?
Yeah, we're not hearing Rebecca. I think she had bandwidth issues.
Okay, yeah, she's still talking, but we can't hear her right now. Can you communicate with her, Tom? And maybe we'll, since we're pushed a bit for time, we'll go on to our final presentation, and then we can maybe have her to summarize as we go into the Q&A. Okay. Okay, well, let's go on to Anna Goslin.
Hi, everyone. Thank you so much for the opportunity to be here today, and for the folks who have sponsored and supported this research. So I'm here to tell you a little bit about a public opinion research project we conducted last year, the insights it generated, and the opportunities we think it speaks to in finding new approaches to engaging the community in advanced care planning. And while I'm going to tell you a little bit about our past research, I want to acknowledge that we are starting right now to develop another round of research that builds on this approach, with a more exclusive focus on communities of color, people with disabilities, and other at-risk groups. Because as you will hear in my slides, not everyone experiences the language and approaches common to advanced care planning similarly. And we think those differences are likely to have magnified during this time of COVID. Next slide. So why did we do this messaging research? Our coalition, based in Massachusetts, was founded in 2016. It's about 125 organizations. And we committed at the start to doing high quality tracking research to monitor our progress over time. We started with a baseline in 2016, asking questions about advanced care planning, experiences with the death of a loved one, among others. We did an open-ended exploration in 2017. And then we did our first real follow-up survey in 2018. Adjusting some of our questions so that we could compare to a large national survey that the Kaiser Family Foundation had conducted the year previous. We found a few things. The public strongly believes that all of this boils down to death, DNRs, and life-sustaining treatment choices, that there is a lot of confusion and jargon. And like so much other research before ours, we found significant disparities in advanced care planning engagement and inequities and experiences at the end of life across race and ethnicity, income, and education. We also learned that despite our efforts in Massachusetts, levels of kind of advanced care planning engagement really didn't budge, and that our state was about the same as the country overall, which, as you heard in one of the talks last week, hasn't actually budged that much as a country for a long time. But we did see an improvement in bereaved caregivers' assessment of their loved one's care. And the more conversations that they had with the clinical team, the more likely they were to report that their loved one's care was high quality and that it very much honored their loved one's wishes. So all of those combined research experiences left us with asking ourselves, how might we approach advanced care planning differently from a public communications perspective? Next slide. So we started asking questions like, are there different ways we can communicate the value of this process? Are there communication strategies that are going to be different for different groups of people? In designing this research, we purposely attempted to shift the language away from end-of-life care and life-sustaining treatment choices. We also wanted to try and emphasize the process and conversations over the documentation, acknowledging that the baseline public perception of all of this is documents about death. Our hope was that by using methodologically rigorous research, we could reveal new approaches that would work across the population as a whole, but also especially speak to the people who are not already engaging in advanced care planning. Next slide. So this is a brief snapshot of the first phase of the research. It was a large scale national, I know we're a Massachusetts coalition, but we decided to make all of this research just nationally representative. So it's a large nationally representative quantitative survey asking questions about advanced care planning behaviors, as well as many other variables that our expert advisors and the literature suggested were connected to advanced care planning, from being a caregiver to personality traits, obviously health status, religion, among others. Then the team used cluster analysis to basically create a small but meaningful set of segments, maximizing the similarity of the segments within themselves and maximizing the differences between the segments. Importantly, those segments were not defined by demographics, age, race, income. because we wanted those segments to represent people's attitudes and experiences, because those are the most important foundations for testing messages and concepts in language. Next slide. Okay, so these are our segments. They break down first into action takers, the two pink groups, and non-action takers, the three greenish blue. Action takers were defined by having a document that names a surrogate and has their wishes for care. And non-action takers do not. It's not that those were the most important actions, it just was very clear that action takers in this way, these documents made people very different from the others that hadn't had these documents. But that's about where the similarities across the segments end. For example, our worried action takers really completed advanced care planning documents because they were worried, often worried about not getting enough life extending care. And this seems to be driven by a very high percentage of them had recently experienced making decisions on behalf of an incapacitated loved one. Our self-assured action takers, on the other hand, seem to have completed advanced care planning just as a course of cultural expectation. They'd completed it, hadn't thought about it, and weren't very worried about a future serious illness. All of our non-action taker segments were also unique in their own ways. Our disengaged warriors, this is our largest segment, lowest income, most diverse, lowest education. They picked every single possible reason we offered as far to why they hadn't engaged in advanced care planning. They were afraid of death, didn't know where to start, don't have anyone to choose, had too many other life priorities. Combined with an overarching kind of low sense of confidence in managing their own health and navigating the healthcare system, you got a sense they were not engaging out of pure overwhelm. Our confident independents, on the other hand, didn't think they needed advanced care planning. Their spouse would know, and they were just fine with that. And last, we had our self-reliant skeptics, a little bit like our disengaged warriors grown up. And what very much set them apart was their marked distrust in the healthcare system. And reflecting on all of these reasons, why not, through the lens of COVID, anxiety, overwhelm, lack of confidence, other life priorities, lack of trust in the healthcare system, these are perceptions and experiences that may have worsened during this time of COVID. And I will note that even though these segments were not built on demographics, there were clearly important demographic skews. For example, self-assured action takers were disproportionately retired Americans, while worried action takers and disengaged warriors were disproportionately Black Americans. These are our segments, and while they're interesting in and of themselves, they're really just the foundations for ensuring that when we're testing ideas and understanding and language, we're doing it in a way that surfaces diverse opinions and experiences and doesn't bias towards the people who've already done the behavior we're seeking to change. Next slide. And so we tested. We pulled together another 150 people, again, nationally representative, to explore and test language, visuals, concepts, existing materials, and as well as these 5 reasons. These are reasons to do advanced care planning. They pretty much sum up all the different ways that we market advanced care planning to the public right now. Advanced care planning is a gift we give to our loved ones, so they won't be burdened by having to make decisions. Advanced care planning gives us peace of mind. It's a way to demand being heard by our clinicians. It gives us a sense of control by picking the person who will speak for us. And it's a way to honor our loved ones who we may be called on to speak for. Next slide. So participants highlighted language that resonated and conversely then highlighted language that they really didn't resonate, it was off-putting. Next slide. Here are some of those lessons from the reasons testing. Some worked well and some didn't. The concept of peace of mind really didn't resonate broadly across all groups, especially for lower income households. Similarly, the concept of lessening or easing the burden on our caregivers was viewed pretty differently by different groups. Some of them, it sounded like it was negative because it shouldn't be a burden to care for our loved ones. And others, kind of, it just felt hollow because having conversations and documenting wishes truly wouldn't actually ease the real burden of caring for a person with serious illness. And lastly, this idea of comparing advanced care planning to kind of a routine wellness kind of checkup, a thing that we do as part of staying healthy, was viewed negatively and as implausible. Next slide. So this table really summarizes all of those reasons by all of those segments. The larger the blue dot, the more it resonated. Those small red dots means it was an actively rejected concept. And you can see there those first 2 columns, to gain control, to demand shared decision-making. Those were 2 that were universally, the only 2 messages that were universally resonant. Next slide. And while those top 2 messages, conversations clarify, and we can have a say in our care, they are not mutually exclusive, but they point to different conceptual elements among the processes that comprise advanced care planning. Conversations clarify is mostly about selecting a surrogate decision maker in case of incapacity. And in the mind of the public, again, this image of incapacity is strongly linked to dying and life-sustaining treatment choices. On the other hand, we can have a say in our care is about creating the expectation and demand for shared decision-making. It is not exclusive to serious illness and death. This concept also shifts more of the responsibility onto the healthcare system and our demands of our clinicians to be heard. It was the most preferred concept overall and was notably the most preferred concept by Black Americans, people with disabilities, and those aged 35 to 65. And again, while these are not mutually exclusive, a major theme of all of this research has been how the very tight connection between advanced care planning and death and life-sustaining treatment choices in the public's mind creates a barrier to engagement, either through fear or for lack of immediate relevance. It even became increasingly clear as we tested that language that phrases just like values, goals, and preferences has become another euphemism for dying. And in some ways this makes sense, that the only time clinicians start talking about values, goals, and preferences is when curative treatments have failed. Next slide. So when we take a step back and look and think of what our reflections are, they're this. If we really want to move advanced care planning upstream in different ways, for younger populations, we have to recognize that the actual risk of a serious illness and incapacity is very low. COVID has definitely changed that perception, and that is likely why we're seeing reports of pretty significant increases in advanced care planning. But when the urgency of COVID passes, we may also see those rates trend back to baseline. So if we're talking to younger folks, we need to keep it light and make it easy to pick a decision maker. On the other hand, if we want to prepare people for in the moment or real-time decision-making, which was so much of the theme of last week's discussion and summarized earlier, this research suggests that another way to prepare people is by normalizing the language and experience of shared decision-making in all healthcare interactions in an equitable and systematic way. By being intentional on listening about life priorities, circumstances, what matters, preferences, talking about treatment benefits and costs, what to expect or trade-offs. This way we are starting early in helping people understand how to translate their lives and experiences into medical decisions. And that way we're never waiting for that finally clear moment when death is on the horizon to talk about goals. We've been practicing these concepts, hopefully within trusted relationships infused with cultural humility all along. Thank you.
Great, thank you so much, Anna. Perfect timing. I think we're going to start the Q&A, but before we do, I just wanted to make sure or to find out if we still have Rebecca with us.
Rebecca, you're unmuted. We should be able to hear you if you are speaking.
Can you hear me?
Yes, we can.
Yay!
Sounds great. Thank you so much. Sorry about
I'm so sorry. I don't know. This has never happened.
That's okay. There are a couple of questions for you, and maybe actually once we get to one, you can take a few minutes, a couple of sentences to summarize, and then we can jump into some questions specifically about dementia. I wanted to start though with a question for all of you. I really enjoyed all of your presentations, and having listened yesterday and today, Scott kicked this off with what might be some flaws, and he landed on one that was talked about a lot last week, which is flaw and evaluation. And in his last slide, he brought up that whole thing again of goal, concordant care. And so I'm curious, having listened to what we talked about as limitations in the evidence, and you all have talked about advanced care planning at different points along the continuum, even as early as messaging and really early advanced care planning to within the context of a specific chronic illness or at the end of life. As we think differently about advanced care planning, how should we be thinking differently about the outcomes that we're evaluating? And I'm going to start with Scott and then have Anna and then Rebecca to answer that.
But I think the approach to advanced care planning, it may be a separate issue and a separable issue from the right ways of evaluating. You know, I think that the evaluation framework stems from what the general goals are. And I think the goals of advanced care planning have been clear for some time, whereas the approach to it or the benefits of it or ability of it to achieve those goals is what's been less clear. You know, we operate in a healthcare system where the default is very strongly towards providing intensive and resuscitative care unless or until someone says stop. So the entire advent of advanced care planning is arguably most pertinent for those who'd like to set some limitations. But I think the concept of goal concordant care recognizes that there are potentially virtues to thinking in advance that go in both directions, conceivably towards more or less aggressive care, and tailoring the care received to the goals of the individual seems pretty unambiguous as something we ought to be striving for. If the issue is we can't measure it, then we can't measure it. But I'm kind of coming around to the idea that perhaps we can, and we just need to test the assumptions that underlie that evaluative framework.
Great. Anna, what are your thoughts?
On what we should be measuring?
Yes, based on what you learned in your messaging work or otherwise.
Yeah, I think that what we learn really strongly from the messaging work is that people want really good, high quality care. And if you're thinking about how they understand a lot of the, I think people understand that advanced care planning should be part of what their expectations of the entire clinical interactions should be. Whether we should be measuring it, I think what it says here is that people would probably want to be measured on whether they feel like they're in control, whether they feel like they're being listened to, whether they feel like they're being supported in their decision making. Again, this was a messaging researcher was talking about advanced care planning, but people's entire experiences are going to be in the context of everything else that's happening in their lives too. And so, but I think that's what this research project speaks to, is that people probably want to have some sort of sense of whether, be able to communicate the level at which they feel heard.
Great. Rebecca, if you can just give us a couple of sentences, just how you think we might be thinking differently about advanced care planning in dementia patients, and including how we might think about evaluating the outcomes that may matter most in that group.
Well, I was almost finished, and I wanted to stress that the whole concept of advanced care planning could deprive people affected by dementia of the ability to make decisions that reflect their contemporaneous circumstances. People who don't lose capacity retain that. So I think that's the moral crux of the moral problem. And then a final point I wanted to make was that people, just because you become affected by dementia or some other intellectual impairment, doesn't mean you can't participate in decision making. We have traditional concepts of assent and dissent, which recognizes the ability of a person who may have some impairments to still weigh in and say what they would prefer. Also, empirical research shows that when surrogates are working with people affected by dementia, they tend to see it primarily as a collaborative approach, where they're interacting and reaching a common decision. And then finally, there's this whole concept of supported decision making, which has been growing. It's recognized in a number of states, which allows people with intellectual impairment to choose a trusted person to make decisions collaborative. So we shouldn't leave them out of the picture and see the advanced plan as representing the patient. When you have somebody here who can respond, perhaps not as articulately, but respond in some ways about what they would like to happen. And so I think what we need to do is recognize that advanced care planning should be discussed with people and conceptually thought about as something that involves not just the planner, but the individual as he or she, could say, evolves or changes, and that individual needs to be part of the consideration too. I think we've neglected the so-called best interest standard, and that's where we need to get better in order to balance these two ethical considerations of well-being for the person with a disability and respect for autonomy.
Great. Thank you so much for sharing that. I'm glad we got a chance to hear the rest of your thoughts on that. I think we probably have time for maybe one more question. And this is something that's come up in a number of different ways in the chat. And I think a good summary of this was posed by one of the question askers here about our approach to advanced care planning. Essentially, he mentions that in our approaches to advanced care planning, we have had a lot of emphasis on the way in which people might judge their odds of achieving a certain type of health status in the face of illness, recovery, and declining as serious illness progresses. And we often have talked about certainly forecasting and preferences, but the concern is that perhaps we continue to over-medicalize this process when in fact most individuals may approach these situations from an orientation based on the social determinants, their cultural preferences and beliefs, and other social constructs. And the question is, as we think about different approaches to advanced care planning, what are approaches that may more completely incorporate the broader context in which people are making these decisions, including their social determinants, their cultural beliefs, and other social constructs? And I might start with Anna on that question.
Sure. Yeah, and I'm just looking at Jane Carmody's comment in the chat about patient priorities care. I think like therein a little bit lies the answer from our experience, is that if you're wanting to be more inclusive of what is going on holistically in people's lives, and also kind of avoid some of the challenges of, imagining future health states, if you're asking people on a continual basis about what's important to them right now, and making sure you're not limiting yourself to the immediate medical world in which you're finding yourselves. And I think patient priorities care, there's the health, like age-friendly health initiatives, What Matters toolkit. I think there's emerging sets of kind of conversational constructs and frameworks where you're actually like pulling in all of those things as a way to, again, help people understand how their life experiences, their goals and preferences on an ongoing basis should be feeding into the way that you make medical decisions. And it's not sort of based on a future state, it's really continuing based on a continually ongoing current state. So I think a lot of that sort of speaks to some of the things that are some of the emerging stuff that's coming out, and very much aligns with what we heard that people actually said they wanted most out of an advanced care planning process was to be involved in the decision making in a kind of different way.
Sorry about that. Thank you so much, Anna. I think we have reached the end of our session. I want to thank all of the presenters for outstanding presentations for this session. We're going to move to the next session, which will be moderated by Dr. Hillary Lum. So I will turn it over to her.
Thanks very much, Dr. Johnson. We're excited about this next panel discussion, Practical Steps to More Effective Advanced Care Planning. And we have 3 experts with substantial expertise. And we can go to the next slide to get to them. So first will be Rebecca Kirch, who is Executive Vice President of Healthcare Quality and Value from the National Patient Advocate Foundation. Then Dr. Julie Childers from Division of General Internal Medicine at University of Pittsburgh. And finally, Dr. Nina Ross O'Connor from University of Pennsylvania Medicine. Their full bios are with the session materials on the web, so I really encourage you to look there, as well as other materials we have. So each presenter will again have 10 minutes. Please do use the chat for your Q&A, and we look forward to a discussion after their presentations. Ms. Kirch, please kick us off.
Thank you so much, Hillary, and good afternoon and good morning, depending on where you're sitting in the United States. I'm in Washington, D.C., where it's a very sunny day, so I have to keep moving to get out of the sunlight, but I appreciate it. I'm Rebecca Kirch, and I'm here representing the patients and families that my organization helps serve every day. The Patient Advocate Foundation may not be familiar to all of you, but we play a special spot in the hearts of people who are underserved and marginalized by providing direct services to help with financial assistance and case management assistance. For example, right now during open enrollment, critically important time for underserved families to get the extra support that they need to find their way through good coverage but also the financial challenges that they face when they're confronting chronic and complex illness. And then the organization that I sit on is the advocacy affiliate, the National Patient Advocate Foundation. And we help support amplifying the voices of these patients and their families in different hallowed halls, whether it's health systems or policymakers' offices or in communities. Really important opportunity to help support what patients and families need. And our organization represents people ranging in over 600 diagnoses. So irrespective of whatever your diagnosis or prognosis is, we are there to help support what patients and families need across different racial and ethnic ethnicities. Our populations are very diverse, but largely we focus on supporting the needs of the working poor, who usually get referred to us as a result of challenges that they're facing. Next slide, please. So I'm going to spin us in a direction around what we know from these populations about what I call the untold backstory of the things that are on our patients' and families' minds when they're confronting serious illness. And it's really a constellation of concerns, some that we've hit on in the presentations today and in last week's session, but a whole lot more around what our volunteers that kicked off this workshop last week, Mo Stewart and Y. Harris, talked about in terms of the insurance coverage, financial impairments that accompany physical impairments of illness, and household material hardships and other concrete hardships that sort of pile on top of the diagnosis and the experience with making decisions about treatment. This chart board features feedback from one of our Can We Talk sessions in the communities that the Patient Advocate Foundation uses to help build confidence in people to talk about what's really on their minds in the context of healthcare and how we can come together to support each other in communities in getting the answers to their most pressing concerns. And you'll see things like access to healthcare, affordable housing. They don't have anything to do with feeding tubes or some of the other information that appears on an advanced directive by necessity, because these are the top of mind concerns that patients and families have. Next slide, please. I'd just like to hit on two key points to really put a finer point on what we know from the underserved communities in terms of the top concerns that patients and their caregivers have in the context of complex and chronic illness. This slide is pretty compelling for us in-house at the Patient Advocate Foundation, and it's unpublished data from surveys we do with our patient population, where we learned about where financial cost of treatment is in terms of ranking different priorities that people have. And it tops out over the possibility of dying, long-term and short-term side effects of treatments. So that's important just to bear in mind that there are, in addition to physical impairments that people endure and side effects that are psychosocial, the financial cost of treatment bears very heavily on their heads and hearts when they're experiencing what the health system is trying to help support. Next slide, please. And in fact, they will characterize avoiding extreme financial distress in the context of a goal of care. So it's not just something that's an afterthought or something we set to the side. For patients and families today, insured or not, employed or not, they are all feeling very much on the edge of a cliff, some all the more closer to it. But avoiding financial distress for themselves and for their families is often characterized by them, and a majority of them and the patients we serve, as their most important goal of care. I think that's important context when we think about, next slide, please. What is the missing marker here in terms of the discussion we're having and the opportunities we have to help support what patients and families have very much on their mind when we're trying to help support them in care planning and shared decision making? And the takeaway I'll invite everyone to consider is thinking about how can we make sure that the financial and social needs that patients and families absolutely prioritize and are very pressing and top of mind, they're often overlooked as part of the care planning conversations that we're trying to construct, and certainly in the context of advanced care planning that focuses on advanced directives, we're missing a mark if we're only focused in that space. Next slide, please. So there are a lot of really good explanations, but I think at this point, given what we've heard from colleagues who are so clever and creative in thinking about how do we do better research, there's no excuse for the missing pieces of the healthcare model now, because what we have is a health system that is very medicalized, and that's a point made in the last presentation session about the opportunity we have now to take where the blue bubble is of the health system and better bridge, if we go to the next slide, what patients and families really are needing as their support opportunity and what's top of mind for them. We really have to stretch our thinking about what care planning means and what it can be, to consider the constraints and concerns that patients and families have beyond the four walls of the clinic or the hospital, to make sure that we're addressing the community-based needs and resources that are actually available to help support these pressing needs. That will help with clinical outcomes. It will help with peace of mind. It will help with adherence to treatment recommendations as well. Next slide, please. So what I wanted to do to round out or kick off our session is harken back to what Y and Mo told us at the beginning of the series and share a little bit of my own family's experience, because about 6 years ago, I've been working in the palliative care sphere for a long time, and I learned from losing my brother to lung cancer over a decade ago how to do things differently. And so with my mom, who's featured here with me at the beach, she was diagnosed with ALS. And so we knew we had to go all in with palliative care and plans and seize the day and relish the moments and make sure that everything we had lined up would fit with the goals that she had. On the left is my beautiful Aunt Sally, who was, she fell to polio when she was 16 years old. And she's here with my grandmother Vivian in an iron lung on her way to Buffalo for 18 months of initial treatment. I was in kindergarten. That's when I last remember Aunt Sally, and it was so cool. She was in a rocking bed, paralyzed from the waist down, but she still enjoyed Halloween, and they dressed her in her bed as a rock garden. She was a hoot. But my mom had very much emblazoned in her brain the experience of her sister. And so when she was diagnosed with ALS, it was all about quality of life and living, and everything about avoiding any kind of artificial breathing. She knew exactly what she did and didn't want. But what she wanted to really know, if we hit on the slide, it'll just give a little reveal. What was really important to my mom to know was, what's going to be like for me when the other shoe drops? Because breathing and losing the ability to breathe is terrifying. What we did is set up a palliative care visit with Pat Coyne. And he walked Mom and I through what it would be like and what support would be available for her, as she called it, when the other shoe dropped, which for her meant when breathing was starting to become a problem. She already had a feeding tube. She knew how to handle that. But the breathing was a non-starter from her. And you can imagine why when you see her sister Sally here in an iron lung. That to my mom would have been a fate worse than death. To harken back on some of the slides we saw from colleagues in earlier presentations. So the opportunity we have now is to make sure that we move ahead with thinking about what can happen. Next slide, and I've just got a minute to go. The missed opportunity we have happened here with my dad and his wife. She was recently diagnosed with colon cancer, and the challenge became that we set up a palliative care visit because we knew that she was going to go home and we were going to need extra supports. All they wanted to focus on was getting that advanced directive completed, but that's not what the family needed at the time. That's what the health system wanted at the time. So we need to think about how can we fix that disconnect by focusing on what patients and families need in the moment. And then we can get to what the health system needs through a process of building trust. So we can skip to the last slide, if you would, because I know I'm running out of time. Keep going, please. Just keep going so we can finish with the final slide, because I want to hit on the policy considerations that I'm hoping that we'll talk about here. The bottom line is we need to move beyond conditioning everyone to talk only about their condition and help support the need for relatable information so that people can make good choices based on what they consider their top needs and concerns, which is very different from what medical professionals see. And the other one I want to highlight is number 4, though these are all important. The quality measures and the payment that we think about in care planning needs to formalize accountability for the training in skilled communication and practice that identifies patient and family priorities and meets their needs. Not just the practice of it, but the training combined with practice. So I'll end there to defer the rest of the time, but thank you for the time.
Thank you so much for the sharing of the story and then leaving us with some policy suggestions and next steps. I'll turn it over to Dr. Childers.
Hi, I'm Julie Childers. I'm a palliative care physician at the University of Pittsburgh. And I'm going to talk a little bit about how we bring decisions and discussions forward and actually operationalize them when a person does get to sicker or to a crisis point, or they at least re-enter the healthcare system. So next slide. So go forward here. So pretty common scenario that those of us in hospital practice see is when a elderly person with advanced disease and comorbidities comes to the hospital, to the emergency department, has a cardiac arrest or another kind of crisis and arrests, undergoes resuscitative measures, and then when the family arrives, they say he never would have wanted this. And eventually it is unearthed that the patient has a PULSE form from a previous admission, or the patient had written advance directives, or otherwise had made his or her wishes known. But the clinicians taking care of the patient in the new location where he is had no way of knowing that. Go forward. So advanced care planning done in the past doesn't have much meaning without the ability to communicate it to the present and to the future. Next slide. And carrying out these advanced care plans has 2 pieces. The first piece is that those of us who see patients in the hospital have to be able to access previous discussions. So I'm going to talk a little bit about the model that we have developed here of how to access in the electronic medical record previous decisions and discussions. And then we have to be able to actually implement those discussions when we have access to them. So we need to be able to communicate with patients or families about the prior decisions that have been made and how we're actually going to implement them in the current setting. Next slide. So our experience at the University of Pittsburgh Medical Center, and I'll give credit for this to other clinicians within palliative care, largely Bob Arnold and other faculty members who spent some time making changes in our electronic medical record such that previous healthcare decisions were prominent. In our system, this has 3 elements. First off, any prior code status or any current code status, presence of a PULSE or other, MOLST, depending on your state, and presence of an advanced directive that's been scanned into the system are all prominently displayed on the top banner bar of the electronic medical record for each patient. Anytime a clinician has a code status discussion with a patient, we require when they put in that code status order, there's a free text box that they have to describe what they actually discussed. And third, we have developed a dedicated goals of care template that's searchable. So when I see a patient, I am able to track every previous discussion that was had in our health system with that patient, as long as it was put into the particular goals of care template part of a previous note. And I'm going to go through what some of these look like in our electronic medical record. Next slide. So this is the patient home on our power chart electronic medical record for inpatients. And the top where the arrow is pointing is the banner bar area. And that's where anyone who has a CPR status from the current admission documented, as well as if there was a POLST or an advanced directives scanned to the chart, are documented at the top blue bar and the banner bar. You see that this patient says CPR assess needed, so that's warning the clinicians that they need to have a conversation and document a CPR status. And then slightly below to the right is the area of the patient home where one can pull up information about previous discussions, advanced directives, goals of care discussions. Next slide. This is what our CPR status order looks like, and this mirrors the POLST form. So rather than being a Chinese menu of options, you can have some of this, a little of that. It basically is, yes to cardiopulmonary resuscitation or no, and then other interventions that may or may not go along with that, along with the box down here at the bottom where the clinician will document who the discussion was had with and what the discussion consisted of. Next slide. This is what the goals of care, advanced care planning area looks like a little bit closer up. And this is where I go when I'm doing an initial palliative care consult for goals of care to see what the previous discussions consisted of. So you can see for this patient, looking down at the bottom, there were 3 recent discussions in the last 12 months. And I can click the view tab to open those up and see what that clinician documented with the discussion and the decisions. Next slide. So that makes it a lot easier for me to see what has happened in the past. And the better that documentation is, the better of a conversation I'm going to have when I'm meeting the patient at the current admission. So if I have access to previous discussions, the first question is, how do I use that information to have a current discussion with the patient or with the family members? I don't want to just look at a previous discussion, previously the patient said they were full code or were DNR, and say, I'm just going to put that order in on this admission. I don't know if something has happened, the patient's perception of their condition has changed as their illness has progressed. They may be in a different clinical situation that they hadn't envisioned when they enacted those previous wishes. So I don't want to go forward without talking to the patient at all. I also don't want to repeat the whole discussion all over again. I can see this a lot, especially for patients who may have made decisions that are a little perhaps maybe contrary to what the doctors might be wanting or assuming them to want. So a patient with advanced illness who is accepting long life-sustaining treatment at the current time often get asked the same question and forced into the same discussion over and over again. And then the patient eventually feels a lack of trust in the healthcare system and feels like their wishes and decisions aren't respected. And also when a patient is getting sicker, maybe they're having symptoms such as shortness of breath, they may be at a crisis point. If I make them have the whole discussion again, it places a heavy decision-making burden on the patient at a time when they may be quite emotional from how they're feeling physically. And that's the kind of scenario in which the doctors go up to patients who are struggling to breathe and say, what do you want us to do? And they get scared and they just say, yes, put me on a breathing machine. So next slide. So the framework that we have developed and that we have been teaching our learners, and I should mention also that we have a paper that you will be able to review in the Journal of Pain and Symptom Management coming out in the coming months that goes through this a little bit more in depth. That's myself, Bob Arnold, and Doug White. But a simplified description of the framework that we've been teaching and that I'm sure many other palliative care clinicians use is that we look at the previous decisions and discussions and orders, and we figure out how much we can use of that previous decision. What's the evidence that those previous discussions and decisions still apply? So some kind of common sense things, like if the discussion was held 3 years ago, I may need to be prepared to go in and start more from scratch. Things may be different. But if it was just a couple weeks ago, a couple months ago, it's more likely to apply to the current situation. If this is a person who said the same thing admission after admission, then I can trust that that their decision-making is consistent, and this decision, whatever it was, may reflect their long-term values? Or did the patient have both an advance directive and a POLST form, which seem consistent with one another? Thirdly, how much information do I have of the values that led to the decision? So when we're documenting code status or goals of care discussion, we encourage providers to actually document what prognosis was discussed with the patient or family, what patient values were discussed, as well as what the decision is made. And then how similar is the current clinical scenario to the one at the time that the decision was made? So next slide. So if I have really strong evidence that the previous decision applies, like the values were clearly laid out, it was fairly recently, it's just a quick check-in. I don't need to put the patient through the whole conversation. I say, do you remember what you decided last time you were here? Has anything changed? And if they say no, then I go ahead and I propose a medical plan that fits whatever they had decided the last time. So I'm taking the burden of making another decision off of the patient. Unless, of course, they say, yes, something has changed, in which case I'll explore more. If the evidence is weaker, like suppose I just have a POLST form that says CPR yes or CPR no, I will first check in, do you remember this form? And tell me a little bit about what you were thinking and what was behind that decision, to make sure that the reasoning and the values are consistent with what the form says. Next slide. So in conclusion, implementing advanced care plans is a challenge that we have worked on in our healthcare system, and we've worked on in terms of thinking about how to have the follow-up discussions when we actually have to implement the advanced care plans. Some steps that we've taken, and I'm sure other institutions have taken as well, is first to make it easy to find the previous documentation in the electronic medical record. Second, to increase the quality of documentation of prior decisions that were made in terms of including the values and the reasons the patient made the decision they did. And third, be able to carry forward previous decisions in an intelligent manner, really evaluating the evidence, talking to the patient, and using that decision to carry forward the previous decision if it seems like there's no reason why things should not have changed. And that's all.
Thank you so much. I see that my internet is unstable, so I'm going to pass it directly to Dr. Nina O'Connors for her presentation.
Great, thank you so much. So it's a pleasure to be here with you today. I'm going to do something a little bit different. We've had a series of really wonderful talks about how to best navigate advanced care planning on an individual level with individual patients or individual clinicians. In the next 10 minutes or so, I'm going to talk a little bit about how you build a system to create effective advanced care planning at the health system level. So as background for this, I lead palliative care at Penn Medicine, and we have 6 hospitals in southeastern Pennsylvania, and then a large network of outpatient practices and home care. And so hopefully we're going to walk through a little bit of our journey in creating a system for this. And I offer this as an example. There are many ways to do this. This may not be the only way to do it, but we'll walk you through some of the considerations in thinking about this from a system perspective. So on the next slide, any of you who've been to Penn recently know that we have a very large construction site where we are creating a new bed tower for one of our downtown hospitals. But I love this photo because it's a bit of an analogy of how we think about creating serious illness care on the health system level. You know, if you think about ideally the workers walk across the platforms and they never need the belt with the safety line, and hopefully no one ever needs the safety net or the safety net below that. But as we've been thinking about creating serious illness care at Penn and advanced care planning, we're thinking about what are the layers in the safety nets to make sure that every single patient has a conversation about what really matters to them. And so as we walk through some of what we've done, you'll see this reinforcement of different systems and different strategies and safety nets, which I think is really key. So on the next slide, These are three really important questions as a health system or even an individual practice or an organization is thinking about how to do advanced care planning. First, they have to think the who, so which patients are you going to focus on, which clinicians, what's the outcome you're trying to drive, and then how are you going to make sure that quality is high and that consistency is there. So we're going to walk through each of those questions. On the next slide, the first question is really the hardest, which patients? We've heard a lot about evidence, a lot about studies, and certainly there are many compelling reasons why every patient could be a target for advanced care planning. But if you're thinking about this from a health system perspective, we have chosen to target and prioritize first those patients who have a serious illness or frailty. And so you can see there the decisions we've made. We started our serious illness conversation initiative in our cancer service line, thinking that that was the place where we might start and have the highest density of patients with more urgent needs for advanced care planning. Our second group was the heart and vascular service line, similarly thinking about patients with advanced heart disease. We're working with geriatrics right now. We have plans with pulmonary and renal. And then also we're starting to work with primary care, but you'll see within primary care, we're going to focus on longitudinal care management. And this is by no means comprehensive. This is not to say that there aren't other patients, and any patient can and should be engaged in advanced care planning. But as a system starts to think about where to work and where to focus, I think being really deliberate on your targets is helpful. The second part is within groups, how are you going to identify the patients who might benefit the most? There will be some motivated patients who ask for advanced care planning and who are thinking about this years in advance. But there are other patients that will never bring this up unless they're asked by someone they trust. And so one strategy we've used in some groups is a question called the surprise question. Would you be surprised if this patient died? In this case, we use in the next 2 years. And there's good literature that this is actually effective at identifying patients who would benefit from advanced care planning. So one strategy is something like the surprise question. On the next slide, we are also increasingly starting to use data and even some predictive analytics to try and make sure that no patients with serious illness slip through the cracks, slip through that safety net we started with. This is an initiative that we are running in our cancer service line. It's called Conversation Connect, and we have a machine learning algorithm that uses data in our electronic health record to identify patients that might be at increased risk of mortality. And it also crosswalks with the advanced care planning section of our health record. So patients that don't have a documented conversation who are high risk are patients we really want to target and make sure they have an opportunity if they want to have a conversation. So in this case, the patients are identified and the provider actually gets a text on the day the patient's coming into the appointment, asking them to consider having a serious illness conversation. And we'll talk a little bit about what that looks like. The providers also get feedback on how they're doing with making sure that all their patients have documented conversations, or at least conversations offered. Obviously, it's up to the patient whether that's a welcome intervention or not. So on the next slide. So we've talked a little bit about which patients. Another consideration is which clinicians. And I think we all have to think about the workforce. While palliative care clinicians and specialists are terrific and really wonderful assets, and referring appropriate patients to palliative care is always a good thing, we do want to build a more scalable workforce. And so at Penn, we've been using this paradigm, this pyramid, to think about making sure we have enough resources for all the patients with serious illness in our health system who would benefit from conversations. We obviously have our specialists. We also are starting to train champions in different areas like the ones I highlighted, like geriatrics or oncology. These are people with extra training who are not specialists, but can be resources for patients and for peers. And then we need to think about what is scalable training for every clinician in our health system so that they're ready to have conversations with patients. So on the next slide. So that's the who. Then there's the what. So which outcome are you going to drive if you are a health system? Are you going to measure advanced directives? Are you going to measure pulse forms? Are you going to measure conversations? And we made a very deliberate decision in our health system to measure conversations. And you'll see there a slide. This is our goal, our audacious goal that everybody is rallied behind. Our goal is that 100% of patients with a serious illness have a documented conversation about their goals, values, and priorities. And you'll see that's not necessarily a medical conversation. That could include any number of non-medical priorities as well, such as the financial concerns and social concerns that were raised. So by focusing on conversations, that unifies the system around one common goal. And documents sometimes result. Documents can be the product of some conversations, and when appropriate, those are important. But we have decided as a system that conversations are the most important goal. You go to the next slide. That decision to focus on conversations helps us also measure how we're doing against that goal. So this is an example of a dashboard. You can see that we have a way of pulling conversations from our health record because we use a specific template. And you can look at how groups are doing. So that's an example of a dashboard for geriatrics and heart failure group. Or we can even drill down to how individual providers are doing. And obviously this is only shared in confidence, but it is helpful to see performance. And then this drives improvement in education and interventions. So that decision to focus on conversations leads to metrics, which allows us to monitor and to keep improving our performance and make sure that all the patients have conversations. And on the next slide. So really important, once you decide which patients are going to be your initial target and then what you're going to focus on, I think we have really an ethical obligation to make sure that those conversations are high quality, that it is a safe experience for patients to talk about these things, and that there's consistency across the health system in what patients and families experience. So there are many ways to do this. We have partnered with Ariadne Labs through the Harvard School of Public Health to use the Serious Illness Conversation Guide. That is a guide of patient-tested language that has mostly open-ended questions that helps clinicians to start conversations and have conversations with patients about what really matters. It keeps the clinician from making it overly medical. It asks more things like what gives you strength and what's most important to you. And so we have that. In addition, training is really important. And if you're going to figure out how to train clinicians across 6 hospitals and many practices, it has to be scalable. So we have a system of 3 hours of training and then coaching that follows the training to help clinicians as they start to have the conversations. And then lastly, the training doesn't produce change unless there's systems change. So thinking about how we prepare patients, how we document conversations, how we remind clinicians about all of this is really important. And you put that all together to try and achieve quality and consistency. So on the next slide. Once you have your program for advanced care planning, serious illness conversations, you want to think about how you're going to monitor the program, how your system is doing, and how you're going to adjust as needed. And we've chosen to do 2 different kinds of monitoring. Obviously, we track the conversations like I've showed you. That's a dashboard that shows about 8,000 conversations from the program we've implemented, which is terrific. But more importantly, we also periodically do patient feedback. And so those are 2 quotes from a feedback session we did in the cancer service line where we asked patients to reflect upon the conversation they recently had with their cancer clinician. And so we do that periodically as well. And I think both those types of monitoring are really important. So then if you go to the next slide, which is my last slide. So take homes for health systems, as we're thinking about this on a system level, I think defining target populations is really important. And we've heard from many people that patients with serious illness and frailty need to be a top priority. Certainly other patients can ask for advanced care planning. I think we're starting to learn how data science can identify patients as that safety net to make sure that patients don't slip through the cracks. Defining conversations as the goal has been key for many health systems, and then methods to scale for scalable training and monitoring are really important as well. Thank you.
Thank you to all 3 of you. I'll invite you to turn on your videos, and if individuals have Q&A, please feel to chat it in. And in the first time, I will go ahead and kick us off. So I am sitting here feeling the tension that has come up in the chat, and especially in the first panel, about how can we really hear from individuals in the challenges of their context, and even figure out how to demedicalize these shared decision-making preparatory conversations. And how can we do that as medical systems? We saw beautiful examples. Thank you for opening up your shop and sharing with us from UPMC and Penn. So that's my question. How can we ensure that these high quality conversations can be less medical? Is it possible? I guess I'll start first with Rebecca and then Julie and Nina.
I'm sorry, can you defer me till a little?
Absolutely, Julie, kick us off.
Well, I mean, I think you say, how can these conversations be less medical? I mean, we are training when we do training, it sounds like we've done some our system-wide trainings, maybe somewhat similar to what they've done at Penn, is, training our clinicians, residents, fellows to really come down to regular English in terms of talking to patients. So asking open-ended questions, asking questions like, what's important to you right now, given what's going on? What are your biggest priorities? And, some people, a lot of times it's not, related to anything that we might interpret as medical. It's related to their spirituality or religion. It's related, their biggest priority might be that their family is taken care of, or as Rebecca mentioned, that, they're not a financial burden on their family. So, and then we ask the clinicians, doctors and other clinicians, to do the job of trying to figure out what kind of medical plans, as well as social plans, that we have access to can help us make sense and convert, help us sort of meet in the middle, matching a medical and services plans to the priorities that the patients give us.
I can go now. Sorry for the delay. In full disclosure, my husband's in the hospital right now, and it was his nephrologist calling me, so I had to tell him I'll call you back later. The joys of the reality of the world. But one of the slides that I didn't get to talk about kind of answers this from the perspective of patients and families, and that everybody's conditioned to talk only about their condition. And I think that's what we've all through this series of this session have tried to grapple with, and Anna's research as well, is we need to help tease out for patients and families the confidence to talk about them as people and treating that person beyond the disease. And everything about what advanced care planning has been, though important, again, medicalizes and conditions people to go outside their comfort zone. Their comfort zone is to talk about what's important to them in the context of their life flow, not what's important in terms of the health system's clinical flow. And when we're trying to make those two things fit, there's nothing but dissonance and lack of receptivity. So I think the opportunity is to restore that faith in and trust in patients to have expertise in their lived experience and help that guide the care planning conversations that happen.
I'll build off those, and I think many times these conversations produce anxiety for clinicians. It may not seem that way to patients, but physicians, nurses, advanced practice providers get very nervous about having these conversations, and that causes them sometimes to retreat into clinical language. So I think training, as Julie mentioned, is a really good way to lower that anxiety. I also have come to really believe that conversation anchors or guides or language that can be easily brought out during a conversation and help clinicians to keep open-ended in their comments can be really helpful, because the clinicians who get anxious tend to bring it to a medical place, and then that closes down the conversation.
Thank you for that. There are a number of questions in the Q&A related to training and also who. And Dr. Ross O'Connor, I really appreciate how you took us through which patients, which clinicians, how do we do this as a system level. So would you be able to tell us and each of you who have worked on training quite a bit, what is perhaps the hardest barrier to overcome with training, and what's perhaps an easier win? And maybe someplace in there, how you motivate people, maybe that's hard or easy.
I can start. We've thought a lot about training, and there was a question about who do you train? You know, who do you train depends on the practice and the patient population. For example, our work in our cancer service line, patients really want to have these conversations with their oncologist. You know, anyone other than their oncologist is not, to the patient, potentially going to feel like the right person. So in cancer, we've trained oncologists as well as advanced practice providers and social workers, you know, as opposed to in primary care where there's much more of a team approach, at least in our system. And we've pulled in community health workers and nurse navigators and care managers. So I think you have to be sensitive to each practice in terms of who can be trained, but really any of those disciplines can do this well if it's the person the patient trusts. What doesn't work well is to insert someone who is not the primary clinician for that condition. You know, if I'm seeing my oncologist, I'm not going to want someone else to come in and talk to me about what I might want next for my cancer, for example. The question about how do you motivate clinicians, you know, I found it's hard to get people over the initial hump of having the conversations and feeling confident in doing it. But once you do that, they often find new confidence, and then it kind of catches, and then it's easy and it's maintainable because it makes the work meaningful and it makes the work easier. Getting them over that hump, I think feedback and data. Sometimes we use peer comparisons. We share patient feedback like the quotes I shared. We make it part of quality reporting, just like any other outcome. You know, clinicians get feedback all the time on other metrics. This is just another metric. So I think those are some of the strategies in addition to appealing to the fact that it's the right thing to do and that it's good for patients.
Anything, yeah, please, Dr. Childers.
Just, you know, to add, I think similar to what Nina said, but making it part of the culture. And I think, and we have trained or given some training to essentially everyone, meaning primary care, oncologists, critical care. However, I think the people for whom it really sticks is when we can get it to them early in their training. So getting in the medical world, the residents, and then training all the fellows. So they sort of grow up with that knowledge and they sort of grow up doing palliative care rotation. So they're competent to do primary palliative care when they finish their training.
And Hillary, I'll just add that the last policy consideration that I included was on this very point of incentivizing the training as an accountability measure. Even before we get to whether or not you achieved goal concordant care, we can measure the percentage of staff who've had dedicated person-centered communication skills training. If I could wave my magic wand, every clinician would go to Aspen and do Vital Talk for several days before they got turned loose on people, while my organization is training people how to talk about themselves with confidence.
Thanks for bringing up policy. I wanted to reflect on that, as well as Dr. Halpern's comment earlier about, you know, motivation plus a value-based payment program or some other sort of structure. So do any of you have examples of how you've leveraged value-based payment program or other sort of positive cultural aspects that have helped practically fuel this work? I don't know who wants to start.
So we have taught clinicians about the advanced care planning codes, which are how you can get reimbursed for having these conversations. I think that has been with mixed effect. Certainly it's important if clinicians spend a lot of time on this, that it can be billed just like another procedure. Sometimes patients are charged extra copays, and that's a real barrier for many clinicians to actually use those codes, and they are complicated and require extra documentation, but I think that's a step forward. Some of our practices are participating in the oncology care model, OCM, or some of the other alternative payment models like primary care first. And those, I think, move forward quality metrics that reward conversations. And so I think those are, some of those are promising, but early.
Yeah, go ahead.
I think we've done similar at our institution, and it's also always a tension between, you know, wanting people to want to do things because it's the right thing versus because they'll get paid for it. So the danger is of having those various incentives is that will people do the minimum to check off the box versus how do we get people to really care about it?
Yes, and I think related to that, with our emphasis on conversations and how both of your systems have invested a lot of infrastructure to measuring conversations and training for conversations. Tell us about how what your sense is for the quality of those conversations, how you're able to get a sense of that. I heard a little bit about patient testimonials as one unique strategy. What other thoughts do you have on measuring the quality of the conversations?
So one other strategy we use, we have a common documentation template, and it includes different domains. Certainly it includes discussion of prognosis, and it includes specific care treatment decisions, but in the middle, it includes things like what gives a particular patient strength, what their greatest worries are, what their greatest priorities are if time is short, things like that. And so we actually look at, you know, to what extent are those different domains completed? How many conversations have more than just CPR status? How many actually include a prognostic discussion? So I think that is not perfect, but it's beginning to get at making sure that conversations are more than just a document or a CPR status. The second thing we've done is we've asked clinicians who use the conversations downstream whether they're helpful. So, you know, talking to hospitalists or ICU physicians, for example, about whether the conversations that happened outpatient were helpful and helped them to take better care of the patients and continue the conversation. And that has also been a place we've gotten really good feedback that we can feed back out to the outpatient practices that are having conversations.
Yes, I think for us, the first wave was getting those changes in the electronic medical record and incentivizing physicians and other clinicians to use the goals of care template in our electronic medical record, especially among certain populations in terms of comorbidities and age. We're now in the middle of a second wave where we actually look at what the clinicians have documented in the goals of care template and assess how much it does reflect the elements of a good discussion. And I know I'm not directly involved in those efforts myself, but I know I've received email feedback about the results of people looking at my goals of care templates that I fill out for patients. So I know it is happening, and it's a work in progress here.
Thank you all to your participation here. And I also want to thank you, Rebecca, for your work in helping to prepare all of us for when we are patients, when we are family members, knowing how to discuss real life, because I think it's as important for us to figure out how we can not just talk about the condition, so that then on the medical side, when it comes time to relay that in a documented note, it actually gets captured, these challenges, these justice issues, the things that really make our individual cultures what they are. So thank you all for your participation. I'm going to pass it back over to Dr. Bob Arnold, who is co-chair of this roundtable and will host the next panel.
So, you know, after all of this discussion, we spent a fair amount of time thinking about how could we make sure that we tried to wrap things up. One of the things that got thought about early is we could have all 406 of you turn your video on, and then we thought that that probably was going to be unworkable. So in fact, what we've done is we've asked a number of people to join us to serve as, to a certain extent, audience surrogates, to reflect on what they've heard over the last 2 days, I'm going to push them with some questions and to try to have a general conversation over the next 35 minutes to try to wrap things up and see if there are any conflicts that we may not resolve or consensus that we can resolve. So I wonder if Diane Myers, Cynthia Carter-Paralat, Millie Solomon, and Abraham Brody can all turn their cameras on. They are all extraordinarily distinguished in their day jobs and have spent the same amount of time watching the first session and now watching this session. And so their job is going to be, I'm going to ask them to just spend maybe 2 or 3 minutes if they have some take-home reflections, and then I have a series of questions, and then I'll get to the 405 participant questions that they may want to ask you. So I'm just going to start and go down on my screen from top to bottom. Ms. Paralat, can you start? I wonder if it's okay with everyone if I just call you by your first name, so we sort of try to make things more similar for everyone. Cynthia, would you be willing to start?
Thank you, Bob. I'd be happy to start. I think first and foremost, I'd just like to comment on just how incredible these last 2 days discussions have been. We've heard from various approaches, certainly the medical, the research portions, obviously. I love the patient advocacy portions. Ethics, it's just been an amazing conversation. So I first want to just thank the team for putting this together. I think overall, there are some really key things that have stood out for me. I think first and foremost, we could all agree that this advanced care planning conversation is one that's tremendously complex. It has various levels. It has various waves and moves, if you will, from so many different angles. But certainly, I think we can all agree it is really a very human issue. And that humanity, the human-centric ness of this space, I think many times is overlooked when we come from a medical scientific perspective. And of course, we recognize the importance of that because we're dealing with patients and families, many times obviously seriously ill, frailty and so forth, fragility and so forth. So I think overall, recognizing the complexity of this, I think Dr. Rebecca Sador certainly pointed that out very clearly in our first sessions. But I'd also like to call out Mo Stewart and Y. Harris. I really appreciate those personal experiences also that really got to the complexity of the gathering of information and how systems are not communicating with one another to really communicate within. Obviously, that's a very central and very challenging subject as well. So there's much to say, and we have other panelists, but I think I just want to call out the complexity. Certainly has been highlighted. It's a very human-centric issue, which I think adds to that complexity, but it also brings me a sense of, how shall I say, appreciation for this space. Yes, there have been 30 years of work and research that have gone into this space, but I leave this space saying that we need to continue even more and even more effectively based on the things that we've learned, our learnings, and the fact that we really need to approach this subject from a human, whole person, truly person-centered approach. And I can speak more to that as we continue our conversation.
Thanks, Diane. You're on mute.
Thanks, Bob. I want to echo Cynthia's vote of thanks and appreciation for the quality of the presentations and the thinking that we've heard both today and last week. But I'll tell you what I'm left with, and I'm reminded of learning about Maslow's hierarchy. And the most important thing in Maslow's hierarchy is access to food and water and shelter. And Rebecca's data shows that many of our families are not confident about any of that. They are rightfully worried that a serious medical illness will bankrupt them and hurt their families. They are rightfully worried that there's no one to take care of them at home. and that their only option if they're in a crisis is to call 911. And so it feels to me as if those of us working to advance care planning are often our little corner focused on maximizing patient self-determination and autonomy, and reality is over here on the other side of the room. And our faith in this illusion of control about what happens to people with serious illness causes us to focus on things that are really not at the top of the priority list for actual patients and families. What's at the top of the priority list is not being bankrupted, being able to pay for their kids' education, being able to put food on the table, being able to get help at home if they're caring for a seriously ill loved one. And we have a healthcare system that doesn't enable any of that. We have a society that doesn't enable any of that. And so I just it also reminds me of that old joke about you dropped your eyeglasses in the parking lot, but you're looking for them under the streetlight because the light is better. So the patient's problems are in the dark parking lot, and we're trying to address their problems under the streetlight, which is advanced care planning. And as a field, I think health professionals have a larger humanistic vision, as Cynthia was describing, and we need to embrace that larger humanistic vision and push for a reallocation of healthcare resources to meet actual human needs. So that is my brief summary.
What I'm hearing you say is that advanced care planning shouldn't be a priority until we solve larger social problems regarding healthcare. Is that?
Basically, a lot of effort, money, time, 30 years of research has gone into trying to perfect advanced care planning. Many people's careers have been devoted to advancing advanced care planning. With very little moving of the needle to be shown for it. And the real problems ever worsening are not in that room.
Okay, Millie, thank you.
Well, Diane and I often follow each other. Remember when we did this in Aspen, and our ideas are very, very similar. She just put it more beautifully in a better organized way than I probably will in the next moment or two. You know, I think I agree, these have been 2 days of great conversation. But I share this frustration that we have been doing this for 30 years, using the tools and talents that are mainly medical to solve a mainly social, financial, and political problem. And so I don't think, Bob, I don't think the takeaway is we shouldn't do advanced care planning until we've solved the bigger social, political, and financial problems. I think we have to do both. And I heard some very exciting systems-oriented approaches to making sure that advanced care planning conversations of the right type occur with the right sets of patients. And I want to say a few more things about that, what goes on inside the clinical setting from a systems approach. That was very exciting, especially this last session where systems made public and visible to us how they're doing that. But this larger question, of the dark parking lot, I think it's not that we should wait until the lights are on in the parking lot. I think we have to all ask ourselves as citizens, not just, if we're acting in our professional roles as bedside clinicians, there's only so many tools available. And so of course we talk about treatment decision-making and advanced care planning at the bedside with individual patients and families, because that's what caregivers do. That's the tools you have available. It's the setting in which you are located. But I think that this larger point about the social and political will to provide the support that an aging population requires is really a citizenship question. And so that's why we can do both at the same time. We can enhance advanced care planning in systemic ways if we get smarter and more organizationally oriented. But I think that since healthcare professionals are highly esteemed, since they know these issues closer and close hand more than anybody else, there is a citizenship role that we can all play as well to try to put in place the kind of society that we want to be, not just the kind of healthcare system we want to be. And so, yes, I don't think it's about waiting. I think it's about doing both in two different dimensions of who we are.
Okay.
Can I just say one more thing about the systems approach? It's more of a question to the group. I feel sometimes when I observe these conversations inside even the very best healthcare systems, that I'm kind of observing a conversation that's almost a bit mad in the sense that it's focused so much on asking patient-centered questions without having provided enough frank context for the patient to understand why you're even asking them their preference. There's a Mad Hatter kind of feeling to this. So I've had this feeling for these 2 days that there's a lot of sophistication at better researching how to hold these patient-centered questions with people. But I haven't heard very much until the last session. I was delighted to hear that Penn has a 3-hour training program. That's extraordinary. That's great. That's what we need, because I feel that providers have to be brave enough, courageous enough to describe what Rebecca's mom wanted to know. I think it was Rebecca Kirch. Do I have that right? You know, what's going to happen to me when the other shoe drops? I don't think we're telling people what's going to happen. What is the likely trajectory of my illness? What kinds of things might I face? Here are the choices that you may confront. Here's some of the things for you to consider. There's a lot that providers should be feeding into these advanced care planning discussions. It's not just about asking open-ended non-medical patient-centered questions, but having the courage to tell somebody that they're in the final phase of their life, and this is what it might look like when the other shoe drops. So those are the two things: systems orientation inside in the clinical world, and acting as citizens because of our specialized knowledge to change the political world.
Well, those are hard acts to follow, right? And when we came in here in the beginning of the first 2 days, Bob, you asked the question, or maybe it was Jim asked the question, you know, do we have anything left to discuss? Well, clearly after these last 2 days, I think the answer that you can provide, there's still a lot left to discuss and a lot left to answer. You know, I agree that, you know, when there are such systemic problems within our society, and then you throw in issues of you know, systemic inequities, mistrust in the healthcare system, particularly amongst people of color, and LGBTQ populations as well. And you have 63% that are focused on financial distress, as Rebecca said. How are you going to deal with this other piece? However, at the same time, it's kind of like waiting for Godot. If you just sit there and wait for all of the social inequities to go away, you're just going to be sitting there and waiting. And so there are opportunities to focus on the advocacy for shifting away from a medical environment and putting more of our money into social spending than in the 120 academic medical centers that take up 25% of our healthcare spending, even though it's about 5% of our healthcare people that are being seen, and focus on both how do we get this out there in pragmatic ways to larger communities that really need the opportunity and are taking care of a different set of patients, and even to remove the patient moniker from it. People, you know, when I sit down for an advanced care planning or goals of care conversation, and the first thing I ask is, tell me about yourself. And they start going through their medical problems. And I say, no, tell me about yourself. there's a look of shock because patients are so used to be treated as patients instead of people that we're not getting to what their needs are. And so it comes back to that. And that's where some of these creative models around healthcare workers. So you have work at an University of Colorado that has focused on using healthcare lay healthcare workers, patient navigators to address events care planning, particularly in that study in Latino populations. You have others focused on social workers taking the lead. It's getting outside of this medicalized realm, but then we still have to come back to how do we connect to getting the system to recognize those pieces. So those two pieces have to come hand in hand, and I'll leave it there because I know we have a lot more to get to.
Cynthia.
Yeah, I wanted to piggyback on what Ab was saying. I totally agree that, and I think we're all saying the same thing, that we really want to look at this issue, again, from a holistic perspective that steps not only works within the medical system, but also outside of the medical system. I think there has to be this congruent approach to really address and attack the needs of community. We heard the statistics about Black and Brown communities, particularly African-American communities, and the disparities that exist. Those of us that are people of color have long known these disparities, and many of us in the healthcare system have as well. COVID certainly has highlighted that. The model that we operate from in the ACCA is one where we train faith-based community care navigators. Is extensive training on not only advanced care planning, but dealing with what health system refer to as the social determinants. So meeting those social needs, housing, transportation, food, issues around how to prepare for a doctor's visit. What kind of questions are important to you so that when you go, as we refer to it, your 15 minutes of fame. Of course, now we're in the COVID period, but yet through telehealth, the issues remain the same, is preparation for the patients. We don't call them patients either. There's so many important issues here to address, but I wanted to just piggyback quickly on, is it AB or AB? I'm sorry. I wanted to say your name correctly. Thank you. I wanted to piggyback because I think it's just really important that we need more hands on deck. Yes, we need the health system, but we also need community to be engaged. So people can be trained to be messengers. But I also should say to you that this is a process. I think we all have learned, if we really want to hear true person-centered care, goal-oriented care, what's important, what values are significant to individuals, we need to have time. And we know that's a commodity, and it's a precious commodity. And so I think it raises this important point that community and trained navigators, I love, I think it was Nina's presentation that spoke about palliative champions. I mean, there are so many levels of participation that we can gain from people that are non-medical also, that can really be supportive in this space. And caregivers, we haven't spoken a lot about caregivers, but the impact that people in community can have in communicating with caregivers so that they too don't have to be a statistic because of the overwhelm that they're experiencing in working with people that have advanced illness. There's so much that can be said, but I will pass the baton to my colleagues.
So I'm going to push you all here. Having listened to the last 2 days, you all gave us new things that we should be doing and how we should change what we're doing. What should we stop doing? Given the data and given what we've heard over the last 2 days, what can we say, you know, this really probably didn't work. We should stop doing it. Diane, I'm going to start with you.
Gee, thanks, Bob.
Okay.
I think the first thing we have to do is to stop conflating advanced care planning with cost savings. Many, many entities, payers in particular, as well as government, has been persuaded, I'm not sure exactly how, that advanced care planning is the key to reducing spending. And there are no data to support that. And that really worries me. The pressure to push advanced care planning, not coming from respect for individuals or wanting to promote relationships between clinicians and patients and families, but actually as a means of reducing healthcare spending. There are no data for that, and it's a dangerous conflation. So that's number one, is to stop putting forward what we do as a way to improve healthcare value. You know, for the Serious Illness Care Project, the Ariadne Labs data is fascinating in this regard, because the randomized controlled trial showed that there was reduced anxiety and depression in the patients. And I don't know if I can't remember if they also measured sense of feeling heard and understood, sense of being well cared for by their clinicians. But last week, Joe Palladino and colleagues published data showing that it had absolutely no impact on utilization of any kind. So we need to separate those things out. And yet the overwhelming motivation for advanced care planning among those of us who are not in this field is about money. And so I think we have to be really super careful about that.
Other speakers, what should we stop doing?
I think we need to stop traumatizing our caregivers and the people that they are caring for. You know, there are studies out there, multiples of them, that show PTSD symptoms amongst caregivers who have had to go through these complex decision-making processes, all the way from ACP to, you know, more immediate goals of care conversations. And part of the reason that I think that probably exists is because we pressure to make decisions right away. And we pressure around what's important to us as healthcare providers and not what is important to the patient and the caregiver. In the end, you know, I might be the one performing CPR, but the person is already dead. If they're dead, they're dead. That's the least important decision, yet it is the one that is brought up the most frequently as the first part of conversation. And so we traumatize them into trying to make these you know, bivariate decisions that don't need to exist and aren't important to them, versus the real issues around who is this person, what was important to them as a person and how they would want to live. And so it's changing the frame of what we are currently doing and throwing away this focus on us and what we are going to be forced to do by indecision, and making it about them and what is positive about the decisions that they are making.
Other comments?
In a way, my response is going to be almost the converse of abs. So I think one thing we should stop doing is worshiping autonomy. And the whole focus on advanced care planning is an instantiation of American fascination with individualism. And instead, the way I think this might be, I'd like to know what Ab's thought is about this, because it's maybe contrary to what he just said. I think we should be focusing on beneficence and care and justice and accountability of the clinical staff to, I'm sorry about this, I'm trying to turn it off. Accountability of the clinicians. I mean, you know, Abby, you just said it almost the opposite, that we should put it about the patients. I'd like to put it about the responsibility and accountability of the healthcare system to make sure that there's some sort of integrated care, that we're just not putting people on a default pattern of specialist care without anybody integrating all the different specialists and finding out how to make an integrated plan. I feel like there's no one in charge, there's no quarterback, as people say. So I'd like to shift from this, we're gonna, you know, this autonomy focused thing to a systems oriented thing that says, what are the responsibilities, obligations, and accountability of the healthcare system to offer something more than a default chute into fragmented specialist care.
And
I
I
would
don't
jump
see this
in.
as diametric. Sorry, Cynthia.
They're
go ahead.
probably complementary, but you emphasize different aspects.
Yeah, I just wanted to jump in really quickly in response to that question, Bob. What should we do differently? I guess I'm reflecting on the definition of insanity that we've all probably heard, and that is that doing the same thing over and over again that we know is ineffective, basically. And I think, given what we've heard, the data, the research, the studies that we've read and heard about for years, and of course the studies and research that we've heard in these past 2 days, I have to be very candid and say I think there's a touch of insanity that, and I'll embrace it personally, if I continue in a mode that says we need to approach people as individuals. We need to consider how we've spent dollars. And Diane, I think you hit the nail on the head when you spoke about a reallocation of resources. I think that we can clearly say that there needs to be a different approach. I come from a marketing communications background. My undergrad is in marketing. And I think there's something really important. We all recognize the importance of communication and language in this space. I really think that we need to step back and do an overall assessment. And certainly the health system partners are important players in that. I think our research partners, obviously, we need community leaders to be a part of this. We need caregivers. We need quote unquote patients. We call them persons needing care in this space. And I'm sure there are other, obviously other important players and stakeholders that need to be in this space. But I think we need to develop what I would refer to as a multi-tiered marketing strategy. And I think the strategy should be layered such that there's a congruent effort that happens in the health systems, which is an important player in this space, within communities, which is an important player in this space, but also a national campaign that includes language and messaging that speaks to the masses. There needs to be a reallocation of funds that really embraces this as an important human-centric initiative that is going to impact every single one of us, whether we're in healthcare, whether we're hospice, palliative care, you name it, we're all human beings, and we're going to have to deal with the issues of making decisions about what we want or don't want as we approach life. And it has to be an approach that speaks to not just serious illness and end of life, but empowering the voice, empowering people to know that what they want for themselves counts. So I would say we just have to, I think it's insane if we continue the same stuff that we've done. We've got enough data and information that tells us that there needs to be this multi-tiered approach, but we need people to come in that are, and this is not no dig at any particular profession, but we do need marketing minds, people that know how to craft language and messaging that can really hit the nail and address all the issues that we know are important. And again, I have to keep coming back to the human-centric, true person-centered approach. And I think we'll find that communities of color will embrace this notion of having individuals trained that can take the time to hear their stories. We have to embrace storytelling and story listening in this space.
So
and
I want to ask a question about that. Millie, you know, if you look at the medical literature about personalized medicine, it really refers to genetic profiling. And so my question is, given that our fascination with science to a certain degree, and with personalized medicine, how do we make the changes that Diane and Cynthia and Ab are calling for in a society which seems to both want time and personalized care, and yet seems very fascinated with every advance that it can find?
Well, that's the that's the $64,000 question, right? You know, you're raising the whole power of the technological imperative and its hold on our imaginations. But I think there has been progress made. You know, in his opening remarks, Bernie said he thought that there'd been more acceptance of surrogate decision-making, he was going way back to the Karen Ann Quinlan case where it was a question as to whether her parents could, the request to withdraw the ventilator would be accepted by her surrogates. And so he's, Bernie and I have a long view. I shouldn't brag about that, but you know what that means. And so it's possible to see progress. I think we're on the cusp of doing better. I think that these 2 days have shown an awful lot of research that has been very nuanced. And I think I really just think we need to shift to having this be a systems change with accountability and responsibility for the care providers to be able to describe what happens when the other shoe fits. In other words, to be able to describe trajectories. I think that our citizens and the people who need care want to know what's likely to happen to them, but it's not being revealed. And so they're being asked their preferences in a vacuum without understanding what their actual situation is. I don't think that's inconsistent with personalized medicine or a focus on genomics. I think it's orthogonal to all that. It's a different matter. And we need to look at the language of the clinical care team as much as we need to look at the readiness of the patients. And I'd like to see more of a shift in that direction towards the accountability and obligations that the system has.
Diane, you had raised your hand earlier. I want to make sure.
Yeah, I just want to remind everyone, and this is aligned with what we're all saying, is that there are more ethical principles underlying the practice of healthcare than autonomy and self-determination. The other ethical principles are justice and equity, beneficence, doing good for patients by their own lights, doing good in a way that aligns with what they think is good, and not doing harm to patients. And all our focus is on honoring self-determination. And we've let the other ethical principles atrophy in terms of their day-to-day influence on our practice. And I think it has taken us, it has deformed the practice of medicine as we essentially ignore these huge social factors that determine the outcomes of more than 80% of our patients. But we're doing fine if we ask them whether they want to be intubated or not, or who they would trust to make medical decisions on their behalf. Check, check. So some of this, I strongly believe that supporting clinicians to have meaningful conversations with people living with serious illness and their families is valuable because the relationship is valuable, because the relationship creates trust, because the relationship helps the person and their family feel valued as fellow human beings. And I think much of the data that shows positive outcomes supports that belief and that we should invest in it, not because it's going to save us, but because it invests in the all-important relationship, without which no medical care can be of high quality or achieve valuable outcomes. So yes, we should keep incentivizing conversations. I love Jennifer Ballantyne's recommendation here that we turn the street light over advanced care planning and make it focus on everything that is important to the person and their family, including whether they have enough to eat, whether they have transportation, whether they're afraid of violence in their neighborhood, that all of those things are our purview. Not just, do you want a ventilator or not?
Bob, could I add something? It's easy to criticize medicine and healthcare, but I also think bioethics itself deserves some criticism here. I'll just use the Hastings Center as an example. We're very proud that we published guidelines on the use of life-sustaining technologies, which help to create the norms for withdrawing or withholding life-sustaining treatments, so to guide bedside decision-making. But about 2 years ago, Nancy Berlinger and I commissioned, co-edited a a volume called "What Does a Just Society Owe Its," something like "What Does a Just Society Owe Its Older Members, its older Americans?" And our first essay in that was calling on the field of bioethics itself to kind of do what Diane just said that medicine should do, and to take within its purview not just clinical bedside decision making, important, we're not saying it's not important, but to go beyond treatment decision making, to go beyond our own guidelines that we were very proud of, to look at what a just society needs to do to express its duties and its obligations to all of its citizens. So I think all of us have to kind of move to a population level set of ethical concerns.
So I'm going to ask Cynthia a last question, which is, there's been a lot of conversation about medicine doing this. To what degree is this healthcare's role versus society's role in general? And is there a cost for locating it within healthcare rather than society? Because I've seen us go back and forth about with those two words. You're muted.
Thank you, Bob. I think there's obviously very much a cost to do this right. And I think that obviously, again, healthcare has an important role in that. But I also think that, you know, we need to do more diligence when it comes to the policy level and make policy changes that speak to this notion that we're speaking now about justice and equity and inclusion, and just the significance. I think the hour that we're in presently, if there ever was a time for us to really more fully embrace DEI and add justice to it as well, DEGEDI, some of my colleagues often refer to justice, right, diversity, equity, and inclusion, is now. And so I think it's a societal issue. Healthcare is a leader, and we need healthcare to lead. But we also need to affect this from a policy perspective as well. And I think we'd be remiss if we did not include, discuss, communicate, and engage our political realm in this important subject matter. I could say some things about our political climate, and hopefully, well, we'll see changes, hopefully, but I think there is much to be said about the role that the political realm plays and policy plays in this space.
So it is 28 after, so I'm gonna get yelled at. Ab, I'm so sorry that I didn't get to your comment. I wanna thank all four of you for your comments. It has been interesting that a conversation that started with a relatively narrow focus about advanced care planning has taken us very far to social determinants of health and politics and policy, and pointing out that if we want some of the things that advanced care planning might have been expected to achieve, at least I've heard from our four speakers that we need to pay way more attention to these other domains, because the 30 years that we might have hoped that advanced care planning would achieve those things, it hasn't achieved all those things. I want to particularly thank the National Academies of Science, Engineering, and Medicine, and Ms. Gregg and her staff for their amazing work. That this is a project that's been about 18 months in planning and has only come to fruition because of their tremendous work and diligence in not letting us all disappear. We will be sending out information. You will all be able to pull up this material and listen to it, and there will be a summary that will be coming out. That's where it will be available on as archive. I want to thank everyone, as well as the group that asked us to do this, and we hope you all have a great week, and stay busy over the next week. And if you have important things that you need to do over this week, we encourage you to do them tomorrow in a timely fashion. Thank you so much.